All patients with significant iron overload, and by that I would mean patients with a liver iron that's probably over 2 or 3, should be treated. Iron is toxic, and it's toxic over a period of many years. There are a lot of nuances involved in the decision of how much and which chelators or which combination of chelators to use. There are also nuances related to young children and their liver iron concentration and the effect of growth. As the child's body size doubles, the concentration of their liver iron will drop because the liver is getting bigger, and they're using the iron in the liver for growth. That's assuming the child is not being chronically transfused. Any patient that's being repeatedly transfused has a continual input of iron and has no way to excrete it, so they must be treated in some way. And our opinion is, if you can safely monitor the total body iron by MRI, that we should try to normalize the total body iron concentration. There are some issues with this in very young children. The growing brain requires iron for intellectual development, and so we are very reticent to start chelation before 2 years of age. There are some certain circumstances in other diseases, not so much in sickle cell disease, where we would consider doing that, but there are issues along those lines that are important. And there are also some issues related to growth with desferol and its effect on bone growth and so forth. So there are a lot of nuances to fine-tune how the iron chelation should be done, especially in very young children, to try to do it safely. It's important that the side effects of the drug be monitored. Each of these medications have different side effects, and so they need to be routinely monitored to make sure that they're not developing kidney problems or neurologic problems or low white blood cell counts, which are going to occur with some of the medications. So careful monitoring is very important. So the starting dose of the chelators is based on body weight. And so that's generally where we start. However, the main thing that in our program, the main thing that we use to regulate the dose are the side effects. We know the usual starting doses of these medications do not give the maximum iron chelation effect. But we always start at the recommended place, and then we increase based upon the patient's tolerance. There are some people that try to adjust these doses based upon their ferritin levels or based upon their liver iron levels. It's my opinion that this doesn't really make very much sense because in an individual patient, there's not such a clear relationship that kind of fine-tuning seems to be helpful. But that's my opinion about this, and not necessarily shared by everything. The overwhelming, most important problem with chelation therapy, and the most important reason it doesn't work, is that the patients don't take the prescribed drug. And this is for a number of reasons having to do with having chronic disease, being in adolescence, and not wanting to be different than your peers. And I think with the disease management of any chronic disease, it requires a different kind of a mindset on the healthcare providers. The patients are going to fall off the wagon and stop chelating. You need to get them back on, and they need to be encouraged. And this means that really the people doing this should have significant experience with this kind of treatment. Because if you don't, you're not going to realize that the treatment actually is going to work, and I think that the patients tune in to these kinds of things from the nursing staff and from the physicians and so forth. Although it's not approved on any of the labels, these drugs can be used in combination, and certain combination of the medications are much more effective than one medication used alone. The underlying principle is that they should have chelator circulating all the time, 7 days a week. And we try to regulate the kind of chelator and the dose and so forth to optimize the likelihood that the patient will tolerate it and will actually take it. This, in my opinion, is far more important than whether you're giving 25 milligrams per kilogram or 30 milligrams per kilogram for some fine-tuning pharmacology. these calculations based on pharmacology are meaningless if the drug isn't being taken.